A full blood count, if it's normal, we can be fairly reassured. A myeloma screen, we can be fairly reassured, but if they persist, we repeat things. So hello and welcome back to season 2 of GPs Talk Cancer. I'm Dr. Rebecca Leon, and joining me again through this podcast is my friend and colleague Dr. Sarah Taylor. How are things, Sarah?
Yeah, good, thank you. Yeah,
good. When we talked about doing this bite-size episode, Sarah, we wanted to make it informative and interesting, but at the same time, we didn't want it to be too dry. So the way we're going to do this is we're going to talk about those blood tests in patients that we want to almost pinpoint a particular cancer, those tests which are more general and we pick up a possible cancer diagnosis, and then we'll talk about some others that are used in secondary care, etc. Okay? So if we start off with those of a male patient presenting with urinary symptoms, I would suspect, or I'd want to rule out, a prostate cancer.
yeah. When we're talking about prostate cancer, we will normally refer to men, but we are obviously referring to anybody who was born with a prostate. Similarly, when we're talking about gynecological cancers, we will often refer to women, but we're talking about anybody who was born with female genital organs. And so that will include some trans patients.
Brilliant. Okay. So a male patient presenting with urinary symptoms. So let's talk about the PSA.
Yeah, and I think it's something that you probably do an awful lot more PSAs than I do, just because of your patient population. It's not a perfect test, but it's useful, isn't it?
Yes, I have the patients kind of early retirement who have come in, discussed it over a round of golf, and actually have been told that they're getting up in the middle of the night to pass urine and they should go and see their GP for a possible PSA check. So it's not perfect, but it is there to be used, and there are false positives and false negatives with the PSA. And as long as you kind of discuss this with the patient, it is a good test.
Yeah, and I think anybody who came to ask me, once I'd had the discussion with them, if they wanted a PSA, I would do the test for them. I would organise the test. I think it's, yeah, and I assume you do too.
Absolutely. So yeah, the PSA is something that we would use for a suspected prostate cancer.
Yeah. CA-125, also useful?
It is useful.
So CA-125, obviously we do in women where we've got a concern about ovarian cancer. But one of the things that struck me from when you did the ovarian cancer module was, again, like PSA, the false positives and false negatives.
Yeah, I mean, CA-125 is normal in 25% of women with ovarian cancer. 25%.
That's a lot, isn't it?
And that, they think, is because that's an early ovarian cancer. It's a bit like with the chest x-rays, 25% are normal with patients with lung cancer. Scary. But it's a good test. And it can also be raised in conditions such as endometriosis, certain bowel conditions, and in pregnancy.
And there's also this stat that I've only recently become aware of, is the significance of raised CA-125 in women over the age of 50. So there's some research that shows that women over the age of 50 who got a raised CA-125 have a 12% chance of having a different cancer other than ovarian. They have a 10% chance of having an ovarian cancer and a 12% chance of having a different cancer. So actually, just investigating a woman with a raised CA-125 for ovarian cancer isn't enough. And we have to think about other things, and we have to come up with pathways to look at other causes for a raised CA-125. So I think that's really important as well, isn't it? I think it's it feels like when the research on the raised platelets came out, when you're thinking, oh, I'd not thought of that before. It's another thing to think about.
So CA-125, don't just think ovarian cancer if it's raised. Think about other forms of cancers as well.
Yeah, and normal CA-125 and persistent symptoms, still think about ovarian cancer. It's a hard job.
It's really hard.
What about let's do the easy ones next. So the ones that I really like as blood tests are things like a full blood count for leukemia.
Can I say a final thing about the CA-125? With women with new onset IBS symptoms, it's a really good test.
Yeah.
I just wanted to mention it.
Yeah, absolutely.
Because it's now in the guidelines.
Yes, yeah. CA-125 is a really useful test for women with new onset IBS, particularly those over the age of 50, as an initial test for possible ovarian cancer. But there are problems.
Okay, so some of the simpler ones, we say simpler because we use PSA and CA-125 tests a lot in general practice.
Yeah, so I think that some of the haematological blood tests are useful in that they do give you a pretty good yes/no answer. So if you do a full blood count because you're worried a patient's got leukemia, if it comes back as normal, then they don't have leukemia. Similarly, although the test's much more difficult to interpret, certainly for those of us in primary care, if you do a myeloma screen, which includes immunoglobulins and either serum free light chains or Bence-Jones proteins, and it's all normal, then the patient doesn't have myeloma. So I think that those, they're quite good, aren't they? I always do feel quite reassured if I see a young patient who is very tired and says they're pale, and I just say, well, I'll do some blood tests, and the full blood count comes back as normal, and I think, well, they've not got leukemia then.
But there's always a caveat. Only because we've just recently spoken to Dr. Guy Macon that we should repeat the blood tests after a month if they're normal, because they can drop. So
Yes, but and that's the symptoms persisting, isn't it?
With anything, it's persisting, progressing. I'm doing eloquent and elegant, informative and intelligent, and now progressive and persisting. So yes, I'm not going to be pedantic, another P, today. But yes, a full blood count, if it's normal, we can be fairly reassured. A myeloma screen, we can be fairly reassured. But if they persist, we repeat things. The myeloma screen is something that I'm using more and more in general practice, particularly my older patients with the longer standing back pain that isn't just down to gardening. It's a good thing to rule out.
I suppose that ties in with some of the other renal functions as well, isn't it? Because when you look at the indications for myeloma screens, it was CRAB, wasn't it? Hypercalcemia, renal function, anemia, and bone pain. Well, the first three of those would be something that you might pick up on the next group of tests that we were going to start talking about, where it's things where you might be doing the tests for a different reason and see something that starts to ring an alarm bell, which is more complicated. So starting, I suppose, with the HbA1c, and you were just telling me something interesting before we started recording about a patient with an HbA1c.
Yeah, it was a lady in her 80s who, a known type 2 diabetic with an HbA1c kind of around 50, and had been stable for years. And we rechecked it on an annual blood test as part of her kind of workup and medication review, and it had shot up to 132. And she's in the process at the moment of having further investigation for a possible pancreatic cancer.
So a new onset raised HbA1c in somebody who you wouldn't expect to be diabetic, or a complete change in diabetic control in somebody who's been fairly stable for a long time, should be a red flag symptom.
Absolutely.
What else do you use as your red flag symptoms on more routine blood tests?
So I suppose from a full blood count, I'd be looking for a drop in HB and whether there's an associated a decrease in MCV with a possible iron deficiency anemia, and think about whether I need to do further primary care investigations like a FIT test and other causes of an iron deficiency anemia. And the other big thing for me is a bone profile as well, because you mentioned calcium, and that could represent bony disease, pathological fractures, etc. And particularly if they've had a previous cancer diagnosis, like a prostate cancer, a breast cancer. So that would also make me think about doing further testing if the bone profile is abnormal.
And I think the one that's also quite difficult is the new onset raised platelets, isn't it? So it's the LEGO-C, isn't it? Lung, esophagogastric, endometrial, gastroesophageal, and colorectal cancers. So new onset raised platelets do have a high association with a cancer. So the positive predictive value of new onset raised platelets is 11% in men and 6% in women. So it's really significant and needs to be taken seriously. You're looking at new onset raised platelets without any other cause. And similarly with the iron deficiency anemia, you're looking for something that's new onset without any other cause. But I think if you just see them in a routine bloods that are done on a chronic disease review, you should be thinking about looking to see how long they've been going on and whether there's another reason. Because obviously if you've got a woman in her 40s who's got very, very heavy periods, you've got a reason for the iron deficiency anemia. If you've got somebody who's had raised platelets for 5 years and they've stayed the same, again, you're not going to be concerned, are you? Where I think it's new onset and unexplained.
I think the other one we need to mention, Sarah, is LFTs, which again we do routinely, and that can test for an HPV primary or metastatic disease. But again, in the early stages, particularly with liver mets, it can be normal and there can still be disease present. So it's not very specific. And finally, with the full blood count, you need to look at white cell counts, neutrophils, lymphocytes to see if there's any bone marrow suppression as well, which is important. Any pancytopenia. Okay, so other tests which may raise concern are inflammatory markers. So ESR, CRP, we do these a lot because inflammation could suggest there could be a cancer, as well as other things like infection and other acute changes. How seriously do you take raised inflammatory markers?
It's all got to be taken in context, hasn't it? So, if you've got other reasons, it's just, I think it's just not as an isolated thing, it wouldn't make me think cancer first, but actually in conjunction with other symptoms, and then it might sort of add another jigsaw piece that made me more concerned.
Okay. We've talked about bone profile. Renal function.
Again, it's a sign of I suppose there are some specific cancers. If you got some renal obstruction, you might get worsening renal function. Otherwise, it's not something that cancer wouldn't be my first thought in somebody with new onset deterioration in renal function, but it might again just add some concern.
Yeah. And liver function tests I've mentioned as well, which can be, again, another part of the jigsaw puzzle.
Yeah, and I think one of the things we talked about when we discussed recurrence of breast cancer is just remembering that normal bone profile, normal liver function don't exclude bone and liver mets. You can have normal blood tests but still have metastases. So it's just being aware of the usefulness of the bloods and when they're not useful.
Yeah. Okay. There's some other tests which are, I think, less related to a potential cancer diagnosis, but we use them in primary care.
Yeah, I suppose it's those tests, isn't it, though, with the non-specific symptoms pathways, which is to exclude cancer. A lot of patients who are referred with things like weight loss, fatigue, this sort of thing. And you wouldn't want to be referring patients on a suspected cancer pathway if there was another clear indication for their symptoms. So I think that it's up to us then to make sure that we've excluded those other things. So that would include things like making sure the patient doesn't have celiac disease if they've lost weight, making sure that the young patient who's tired doesn't have glandular fever, that they're not HIV positive, that thyroid function is normal, and that, if you've got a raised inflammatory marker, that the autoimmune screens are normal. So I think it's just that sort of checklist of investigations where you would probably add on, as well as for non-blood investigations, possibly chest x-ray, definitely fit, and probably a urine dipstick as well, just because if you've got non-specific symptoms, you want to exclude other clear causes.
To be sending somebody to an RDC and they're actually hypothyroid, it would be not great.
No, absolutely.
There's certain blood tests that we don't get too involved with, and often secondary or tertiary care ask us, and that does include the PSA for surveillance, often 6 monthly or annual, to check what the pattern is with the PSAs. But the other ones are CEA, which is a bowel cancer marker, and the other one is a CA-125. So again, it's not something that we would probably do off our own back, but we're sometimes asked as part of a surveillance.
Yeah, and I don't, certainly from the pancreatic one, I don't think that it's something that's used in diagnosis, is it? It's used for surveillance.
Yeah.
So I think that, the blood tests in primary care, as we said at the start, we do a lot of blood tests. I think that it's really important with all of them just to be aware that they can be false negatives and false positives, and it's easy to get reassured by something being normal.
And why I thought it was important, or we thought it was important to do this bite size, and it may be our listeners thinking, why are you telling us this when we know it, or whatever. It's because whenever you organise a blood test, you need to be thinking why you're organising it, and am I interpreting, and am I looking at that next step. So you see a raised platelet, what you're going to do about it. You're going to look back to see what is the pattern, has it always been raised, is it a new finding, and do I actually need to delve a bit deeper? Could it be something significant?
So I think my 2 take-homes would be, remember that things like PSA and CA-125 can have false negatives as well as false positives. And then just remember that HbA1c can indicate a new pancreatic cancer, that new onset raised platelets can indicate the LEGO-C cancers, and that CA-125 does link to other cancers other than just ovarian, and don't be overly reassured.
My take-homes, myeloma screens, I think it's a really good test, and when you can be fairly reassured that if it comes back normal, then the patient doesn't have myeloma. And the other thing also is don't rely too heavily on tests such as LFTs and bone profile for saying that this person doesn't have metastatic disease, because actually they could still have it with normal blood results. And finally, my second or third take-home message is, even though we're talking about cancer as GPs, we see a lot of things that aren't cancer. So it's important to do other tests like a celiac test, a thyroid, an HIV screen, an autoimmune screen to exclude other causes which isn't cancer but may present with similar symptomology. So thank you, Sarah, and thank you for listening to this podcast from GatewayC. We've got a free cancer module which is available on the GatewayC website. All reference studies and guidelines will be in our show notes. Thank you to our producers, Joe Newshome from Rethink Audio and Louise Harbord from GatewayC. Please do press the follow button so you don't miss out on future episodes. And we'd love it if you shared this podcast with your friends or colleagues. It really does help spread the word. Thank you, and we'll see you again soon.